And then after we've conducted our thorough subjective exam, we're moving through our objective examination, where the fundamental areas are observation, palpation, stretch tolerance, getting a grasp on isolated calf function, and our dynamic calf capacity as well. In terms of observation, observing locally, are there differences in relative calf bulk in terms of the size of the calf and what you can see of both the medial and lateral gastrocnemius heads and the soleus and where that's positioned. Is it a sort of high position with the gastroc versus those cases where they have the morphology more uniform along the shank? Are there visible signs of a severe calf injury, such as bruising or a focal defect? Are there observable signs of contusions or injuries to other structures, such as the Achilles tendon? So I always advocate taking time to observe the calf before moving on to other tests. Also observing the relative bulk of the posterior muscles and those that will be synergistic with the calf during the stance phase of running. So having a look at, are there differences in the bulk of their posterior glute max, their hamstrings, and also their quadriceps, and that could point us to impairments in those regions. Then we're palpating the calf, identifying areas of tenderness, and if there is a discrete location of tenderness, specifically in either head of gastrocs, soleus itself. It's always good to palpate along the course of the Achilles tendon as well, and we're looking for if we're eliciting pain out of 10, as well as getting a score of maximal length of tenderness in centimetres. And those two factors are things that you then track in the rehabilitation, where you expect pain scores out of 10 to resolve and that tenderness length to resolve as well, certainly by the time you're returning to play. You're looking at the tactile qualities while you're palpating as well. Is there an area of focal spasm? Is there a palpable defect or deformity, which can be more obvious with Achilles tendon insults versus a calf strain? And it certainly can be more obvious with superficial medial gastrocnemius injuries if there's been an extensive injury in that distal muscle tendon junction and involving the free connective tissue aponeurosis. And during the palpation as well, getting a feel for, has there been a direct injury such as a contusion in contact sports, because this is an important part of the differential diagnosis, in that some of those other injuries can have symptoms that masquerade as a calf strain. And here we're looking at a straight leg stretch, which is part of the objective examination of a calf injury, and a bent leg stretch as well, where typically greater sensitivity to a straight leg stretch is associated with gastrocnemius injuries, given the biarticular nature of gastroc, versus greater sensitivity during a bent knee stretch is associated with soleus injuries. Although I will say as well, that's not a hard and fast rule, and I've seen many soleus injuries that buck the trend and are more sensitive to straight knee stretch, and vice versa with gastrocnemius strains.
Even very mild strains, do you often see sensitivity to stretch, or some people won't have that sensitivity on?
Yeah, great question. Not necessarily.
Yeah.
So mild injuries, it may just be when you begin to introduce them to high load tasks that you notice an impairment, and they could be completely fine with straight leg stretch.
Yeah.
In terms of tracking resolution of symptoms over time, I'd advocate getting the tape measure out and measuring straight knee tolerance and bent knee stretch, including bent knee just with a lunge at the wall, and then tracking the normalisation of that over time, where you would be expecting that to get back to normal before you're returning to play.
Yeah.
We're examining, as I mentioned, that bent knee stretch, where you're interested in the onset of symptoms when that occurs, and where that's occurring in the calf. Is it a diffuse symptom, or is it focal and localised to a specific area or a band of tissue? And I'd be measuring this with a ruler or the tape on the ground to get an objective score.
Yeah, and comparing it obviously to the other side. Yeah.
And so here again, we have the information about what we're looking at in terms of those stretch tolerance tests. If it's a more severe injury or you're suspecting a more pronounced pathology, you can be doing passive dorsiflexion stretches in non-weight bearing positions first to measure their range of motion. For mild injuries, there usually isn't an impairment in non-weight bearing positions. So it's a good habit to get into clinically. And then, as mentioned, our weight bearing range of motion tests, specifically our bent knee stretch and or knee to wall lunge, where we're looking at that weight bearing range of motion. We're getting a feel for if there's an asymmetry. Is it pain we're eliciting or other symptoms? And what is that symptom quality? Tightness, cramping and so forth, followed by our straight leg stretch at the wall. After doing our stretch tolerance, looking at isolated calf function, which again, you can look at manually in non-weight bearing positions first, with the knee extended and the knee flexed, with that common principle that with the knee flexed, identifying symptoms or an impairment could be more associated with a soleus injury. With the knee extended, conversely, perhaps a gastrocnemius injury, although it doesn't always follow that rule. After getting an appreciation for isometric contraction, doing a calf raise gamut in weight bearing conditions through range, with the knee extended and the knee flexed, to get an understanding of what they can do in terms of their capacity. Are they experiencing pain, or are they other symptoms? And I want to raise as well with this, in the absence of symptoms, are they using or utilising an antalgic strategy? So it could be that they're not reporting to you that they're feeling pain in their calf, but clearly they're hitching from their hip and they're using their quad to execute the calf raise, and they're really not using their calf muscles at all. I'd grade the difficulty with this calf raise gamut, beginning with double leg calf raises into double leg concentric, single leg eccentric, followed by a stock standard single leg calf raise. And the reason that you're doing that is that if you grade it, you get a precise understanding of what their capacity is specifically, which will then tie into your entry level loading strategies.
So I think we've got an older athlete model here with a history of a
right-sided calf injury.
Will you have a look and see what you can see?
So here, moving through the calf raise gamut, beginning with a two-leg calf raise, where we can see differences in relative bulk, right versus left, fairly obvious. Our model there in Brooke. And so as we move through this gamut clinically, checking in with the patient, is this eliciting any symptoms? Are they having frank pain? Is it more diffuse in nature? And you certainly don't need to execute all of these capacity tests. For example, if you're identifying that the patient has significant pain with a two-leg calf raise, that's their level of capacity clearly. You don't need to then push them along at risk of exacerbating the injury site. And here we can see the single leg calf raise on the right side, where perhaps we aren't getting the quality in terms of inner range, if I was being picky, the foot's in an everted pronated starting position that isn't optimal as well.
Okay.
And then here we're looking at the bent knee calf raise position, working through that same process, beginning with 2 legs, grading their function, followed by 2 leg concentric, single leg eccentric. And a classic sign of reduced capacity in this position will be the shakiness on the eccentric phase.
I think I do a couple on the right.
Yeah.
Yeah, and I definitely do get that diffuse pain on my right if I up my load in any running at the moment.
Yep.
So yeah, clearly some deficits still there.
And yeah, these simple tests can be, you know, really powerful in the ongoing monitoring of athletes after return to play, to identify how their mechanics are, what their level of function is, and how successful they've been in strengthening their calf.
Yeah.
So after we've evaluated their stretch tolerance and their contraction, we move on to dynamic capacity, beginning with plyometric function. And again, being systematic with how we grade this to get that precise understanding of what their capacity is. And then that informs our expectations about severity. For severe calf injuries, where, you know, they're still painful walking, they can't execute a 2-leg calf raise, this part of the assessment won't occur acutely, and this is something that you'll look at as they resolve in terms of their symptoms.
Yeah.
But starting, when we do introduce it, double leg vertical, followed by single leg vertical, followed by single leg horizontal. Reason being that with the more vertically oriented plyometrics, there's a smaller rate of loading and magnitude of loading challenge, and also a smaller lengthening demand on the muscle tendon unit. But as soon as we introduce that horizontal component, it's significantly more demanding in those areas. And once we've evaluated their plyometric function, got an understanding of that, looking at locomotive activities. So grading from walking, submaximal jogging, linear run-throughs, cutting and change of direction tasks, sprinting, and finally maximum acceleration. But again, significant calf injuries, you won't get to this stage of assessment acutely.
So if they could do a, say, single leg straight knee and bent knee, what grade would you then enter them in for this plyometric function? Would you start with a double leg vertical, and then would you, if they were okay with that, then obviously,
Yep, so great question. If they've graduated to a plyometric assessment, following the same process, where you're always beginning 2 legs vertical, followed by single leg vertical, followed by single leg horizontal. And it might be just a number of reps that you ask them to complete, 5 repetitions, or it could be a duration. For example, 10 seconds or 15 seconds. And I will stress as well, these are sub-maximal in intensity. So, you know, I have heard of cases where patients get a little bit excited and they do some forward hops for max distance and restrain their calf. So sub-maximal intensity, getting a grasp on, are there symptoms, what is their movement quality, is there an antalgic strategy, and so forth.
And if they come in and they can walk pain-free, they can do all of those plyos and strength, would you get them then to go for a jog, or is there anything else you would want to tick off before you get them running?
We'll go through that specifically. There is a slide on clearance to run, where you would do something slightly more demanding, which is a timed single leg hop test for 20 seconds.
I'm jumping the gun, sorry.
We've jumped the gun slightly, but it threads in well with this content. To be continued.
I think we've got some videos of the plyo stuff,
So here we're looking at a 2-leg vertically oriented plyo, just with a 2-leg pogo, followed by some single leg in-place hops. Comparing any differences between sides with respect to mechanics, as well as asking the patient, are they experiencing any symptoms? Here we're introducing a forward component, which again, as soon as we have that greater horizontal demand, things become more stressful for the calf muscle tendon unit, followed by some single leg hops in series, where again, I'd prescribe these to be submaximal in nature, asking the patient to do 4 to 5 submaximal forward hops, which is quite demanding for the calf to be able to do that. So if a patient has got through to this part of the assessment, you'd be expecting that the pathology is not as severe.